Rheumatoid arthritis is an autoimmune condition in which the body produces IgM or IgG antibodies against the Fc portion of IgG molecules. These immune complexes generate an inflammatory response, which is classified as a type 3 hypersensitivity reaction. Diagnosis of rheumatoid arthritis requires a combination of radiologic, clinical, and laboratory findings. In the laboratory, we commonly see high titers of rheumatoid factor, low titers of complement, and positive anti-cyclic citrullonated peptide, or anti-CCP. The screening test is the rheumatoid factor assay. In this test, patient serum is added to a reagent composed of a particulate carrier, such as latex or red blood cells, coated with IgG. After running positive and negative controls, a positive result is shown by visible agglutination. This assay primarily detects IgM. For confirmation, we use the anti-CCP test, which is based on the ELISA technique. This test has high sensitivity and specificity, allows earlier diagnosis, and provides the opportunity for earlier treatment that may reduce joint erosion and deformity. Other autoimmune disorders, including systemic lupus erythematosus, Sjogren syndrome, Scleroderma, and rheumatoid arthritis, are evaluated using anti-nuclear antibody testing. Screening can be done by ELISA, which is easier and more cost-effective, or by indirect immunofluorescence using HEP2 cells, which provides detailed titers and patterns. In multiple sclerosis, autoantibodies target the myelin sheath of nerves or myelin basic protein. In this case, laboratory findings typically reveal oligoclonal IgG bands in cerebrospinal fluid but not in serum, indicating local antibody production in the central nervous system. Let's talk about autoimmune thyroid diseases, focusing on Graves' disease and Hashimoto's thyroiditis. Graves' disease results in hyperthyroidism, which means an overproduction of thyroid hormones. In this condition, autoantibodies are directed against the thyroid-stimulating hormone receptors on thyroid cells. Because of this constant stimulation, thyroid hormone production continues unchecked. In laboratory results, thyroid-stimulating hormone, or TSH, is typically low, while thyroid antibodies are elevated. These antibodies include thyroid peroxidase antibody, also called anti-TPO, thyroid-stimulating hormone receptor antibody, abbreviated TRAb, and thyroid-stimulating immunoglobulin, or TSI. The thyroid glands are often enlarged, and diffuse goiter may be present. Patients usually experience symptoms such as weight loss and anxiety. Now let's look at Hashimoto's thyroiditis. This condition results in hypothyroidism, or inadequate production of thyroid hormone. In this disease, autoantibodies are produced against thyroglobulin and other thyroid cell components. Here, TSH is typically elevated, while thyroid antibodies are also elevated. The main antibodies include thyroid peroxidase antibody, or anti-TPO, and thyroglobulin antibody, or anti-TG. Anti-TG may also be seen in thyroid cancer. The main symptoms of Hashimoto's thyroiditis are weight gain, lethargy, and intolerance to cold. In summary, Graves' disease leads to hyperthyroidism with low TSH and excessive thyroid hormone production, while Hashimoto's thyroiditis leads to hypothyroidism with high TSH and inadequate thyroid hormone levels. Both conditions are strongly associated with elevated thyroid antibodies. Celiac disease, also called celiac sprue, is an autoimmune disorder caused by hypersensitivity to gliadin, a protein found in gluten. Gluten is present in grains such as wheat, barley, and rye. When individuals with this sensitivity consume gluten, their immune system responds inappropriately, leading to inflammation and damage in the small intestine. This results in poor absorption of nutrients. From a laboratory perspective, the tissue transglutaminase antibody test, also known as TTG, is considered the best and most reliable screening test. Both TTG-IgA and TTG-IgG are used. Other antibody tests include the endomysial antibody test, or EMA-IgA, and the anti-gliadin antibody tests, which can be either IgG or IgA. Finally, genetics also play a role. Nearly all patients with celiac disease carry HLA-DQ2 or HLA-DQ8 alleles. These genetic markers are not diagnostic by themselves, but their presence strongly supports the diagnosis when combined with antibody testing. This table organizes key autoimmune diseases alongside the specific autoantibodies they produce. In Graves' disease, autoantibodies are directed against the receptors for thyroid-stimulating hormone, leading to overactive thyroid function. In Goodpasture's disease, the target is the basement membrane of the kidneys and lungs, resulting in organ damage. In Hashimoto's thyroiditis, the antibodies attack thyroglobulin, contributing to hypothyroidism. In multiple sclerosis, the autoantibodies attack the myelin sheath of nerves or myelin basic protein, disrupting nerve conduction. In myasthenia gravis, antibodies are directed against acetylcholine receptors at neuromuscular junctions, leading to muscle weakness. In rheumatoid arthritis, the antibody is an IMG directed against the Fc portion of IgG, commonly known as rheumatoid factor. Finally, in Sjogren's syndrome, autoantibodies attack the salivary and tear ducts, causing dryness of the mouth and eyes. This flowchart explains how laboratory testing for anti-nuclear antibodies, ANA, proceeds step by step. If the pattern is homogeneous or peripheral, meaning mitotic positive, the next step is confirmation using the Crithidia test. If the Crithidia test is positive, the result points to anti-double-stranded DNA antibodies, which are diagnostic for systemic lupus erythematosus, SLE. If Crithidia is negative, we then consider anti-DNP antibodies, sometimes referred to as the lupus erythematosus factor. If the pattern is speckled, which is mitotic negative, two pathways are possible. A confirmation test for anti-centromere antibodies, which is associated with CREST Syndrome. A confirmation test for anti-ENA, extractable nuclear antigen, which can reveal anti-SM linked to SLE anti-RNP seen in mixed connective tissue disease, MCTD, anti-SSA and anti-SSB, typical of Sjogren's syndrome, anti-RANA, associated with rheumatoid arthritis, and anti-SCL70, linked with Scleroderma. If the pattern is nucleolar, it is most often associated with progressive systemic sclerosis, or sometimes Sjogren's syndrome. If the result is negative, this usually rules out SLE, though it's important to note that about 5% of SLE patients can still test negative. This structured flow allows clinicians to interpret ANA patterns step by step, moving from broad screening to more specific confirmatory tests, ensuring accurate autoimmune disease diagnosis. Anti-nuclear antibody testing can produce different patterns, each associated with specific antibodies and diseases. Homogeneous or diffuse pattern. This is linked to antibodies against native DNA, also called nDNA, and against histones. It is usually seen in systemic lupus erythematosus, or SLE, and in drug-induced lupus. Peripheral, or rim pattern. This shows antibodies against double-stranded DNA. It is highly suggestive of systemic lupus erythematosus. Speckled pattern. This is associated with antibodies against RNA and extractable nuclear antigens, or ENA. Clinically, it can be seen in SLE, Scleroderma, rheumatoid arthritis, and mixed connective tissue disease. Nucleolar pattern. This corresponds to antibodies against nucleolar RNA and against RNP. It is characteristic of Scleroderma and connective tissue diseases. Centromere pattern. Here, antibodies are directed against proteins in the centromere of chromosomes. This is strongly linked to CREST syndrome. This table helps clinicians interpret ANA patterns in the context of autoimmune diseases. Let's discuss cancer tumor markers. Tumor markers are substances that may be synthesized and released directly by a tumor, or they may be produced by the host in response to the tumor. These markers can be found in circulation, in body cavity fluids, on the cell membranes, or even inside the cytoplasm or nucleus of a cell. In healthy individuals, tumor markers are either completely absent or present only in very small trace amounts. When they appear at elevated levels, this can indicate the presence of malignancy or active tumor growth. Clinically, tumor markers serve several purposes. They are used to help with diagnosis, to determine how far a disease has progressed, and to guide physicians in choosing the most effective therapeutic drugs. They also allow laboratories to monitor how well a patient is responding to treatment. And perhaps most importantly, they are very useful in detecting recurrence of cancer after treatment. In fact, monitoring for recurrence is considered their most common clinical use. From a laboratory perspective, testing for tumor markers is most often performed using the enzyme-linked immunosorbent assay, also known as ELISA. This method provides high sensitivity and specificity, making it reliable and reproducible for clinical use. Let's go over the tumor markers for learning reinforcement. Tumor markers are substances either produced directly by tumors or by the body in response to tumor activity. They are used in diagnosis, monitoring disease progression, guiding therapy, and most importantly, detecting recurrence. Alpha-fetoprotein, AFP, is linked to cancers of the liver, ovary, and testes, especially teratoblastomas. Carcinoembryonic antigen, CEA, is associated with colon, breast, and lung cancers. CA15-1 and BR27-29 are both markers for breast cancer. CA125 is primarily used in ovarian cancer. CA19-9 is linked to pancreatic cancer. Estrogen and progesterone receptors are important in breast cancer evaluation. Prostate-specific antigen, or PSA, is specific for prostate cancer. Human chorionic gonadotropin, or HCG, is found in testicular cancer. Finally, beta-2 microglobulin is associated with multiple myeloma and chronic lymphocytic leukemia. Let's go over some relevant diseases and the corresponding impaired immune function. Impaired immune function refers to conditions where the body's defense mechanisms are weakened or dysfunctional. Chronic granulomatous disease is marked by ineffective phagocytosis, meaning immune cells cannot effectively engulf and destroy pathogens. Celiac-Higashi syndrome is characterized by impaired neutrophil function, reducing the body's ability to fight bacterial infections. Di-George's syndrome involves T-cell deficiency due to the absence of the thymus, which severely weakens adaptive immunity. Human immunodeficiency virus, HIV, lowers T helper cell counts, decreases the helper to suppressor cell ratio, and reduces T-cell proliferation, leading to progressive immune suppression. Wiskott-Aldrich syndrome presents as a partial combined immunodeficiency, impacting both T and B cells. Severe combined immunodeficiency disease, SCID, is the most severe, with a complete or marked deficiency of both T and B lymphocytes, leaving the patient highly susceptible to infections.